All right. Hello, good afternoon, everybody. My name is Damani Joseph, and today I'll be presenting a presentation on the factors involved in informed consent for surgical treatment on behalf of Dr. D. Ramnarayan, who is the tutor for this presentation. All right, so for this presentation, just going over an overview. So we'll be going over what are the different types of consent. We will describe exactly what is informed consent. We'll go over a brief history of informed consent. We will go through the requirements and elements for informed consent. We will go through what makes consent valid. We will discuss the decision-making capacity, informed consent in the pediatric population, and what are some exceptions to informed consent and the withdrawal of consent. So just in general, consent can be broken up into two forms. So it could be either implied or expressed. So implied consent is consent that is demonstrated by the acts of the patient. For example, if a patient presents themselves to an examination room on their own free will, this is implying that they are given consent to be examined and discussed with. Express consent can either be written or verbal, and informed consent can be described as a combination of these two things. So what exactly is informed consent? So it is not merely a signature on a form, but a crucial component of medical practice that ensures patients have the necessary information to make informed decisions about their care. It's a process that involves clear communication between the healthcare provider and the patient, in which the provider explains the potential benefits, the risks, and the alternatives of a treatment procedure. The patient then has an opportunity to ask questions and provide their consent to the recommended treatment or procedure. Just to go over a brief history of informed consent. So in the practice of surgery, informed consent is a relatively new trend. During the 19th and early 20th centuries, patients were rarely involved in the decision-making process regarding their medical care. So physicians practice more of something called benign paternalism. That is where they were viewed as the experts who made the decisions on behalf of the patients for their own good. But over the last 150 years, the public consensus has shifted away from this concept of doctors establishing the standard of care to the model where well-informed patient is the master of his or her own body. So that is a description of patient autonomy. So as surgery has become more patient-centered, the practice of informed consent has emerged. Just to tie it all together with some significant historical value, there's a landmark case between Canterbury and Spence. This occurred in 1974. In this case, a patient sought assessment from a neurosurgeon for back pain. After the initial investigation with a myelogram, a T4 disc herniation was diagnosed and a laminectomy was advised and performed uneventfully. In the preoperative period, the doctor neither gave a thorough description of the procedure, nor was the complication of paralysis discussed. The patient went on to do well postoperatively until he fell from a bed while in the hospital and he incurred a T4 complete paraplegia. This patient brought a medical malpractice suit against Dr. Spence and the hospital. So as a consequence of this case, the court basically rejected the professional practice standard in favor of the reasonable person standard. So this is whereby doctors are obliged to disclose to the patient all information regarding the diagnosis, the treatment options, the different risks that a reasonable patient in a similar situation would want to know. So this reasonable person standard empowers the public, which are the reasonable persons, to determine how much information should be disclosed by medical practitioners to ensure that consent is truly informed. So what are the requirements for informed consent? So there's 6 requirements that I'm going to go over. The first one would be the patient must be aware of the diagnosis. They must be aware of any diagnostic procedures that are necessary to ascertain the diagnosis. The surgical procedure must be explained in a way that they understand. The patient must be informed of any inevitable risks from surgery. These are the frequent outcomes of surgery and any collateral risks. So these are any complications that arise indirectly as a result of the surgery. And the patient must be informed of all alternative methods for treatment. This could either be surgical or conservative treatment. And the expected results and their probability should be discussed in sufficient detail for the patient for them to understand. And this all happens prior to a surgical procedure. So just bullet point the elements for informed consent, as discussed in the previous slide, would be broadly disclosure, that is disclosing all of the information that is necessary. Comprehension, making sure the patient understands, making sure that the consent is given voluntarily, that the patient has competence and they agree and therefore would sign the consent. So what are the benefits of informed consent? So it enhances the physician-patient relationship. It allows the patient to engage in his or her own healthcare. It encourages doctors to thoroughly review the patient's therapeutic options, and it reduces discontent and litigation when there are complications, or if there are complications post-op. All right, so moving on to the slide, this is an image that gives an algorithm for navigating the process of informed consent. So it starts with the patient. They would either establish themselves as the key decision maker. If they are, then you engage directly with the patient along the informed consent pathway. If they are not, then you have to identify the patient's cultural identity, if they have any explicit preferences for making decisions, and you want to understand the degree of family involvement. All the while, you still want to maintain a heightened awareness of the patient family or the patient surrogate interactions. So during this process, you're continuously reassessing for signs that the patient is unhappy with their role in the informed consent process. You have to make sure that the family or surrogate is willing in this situation, and make sure that the patient has not deferred the decision-making involuntarily. So on the side, you'll have a secure private conversation with the patient and remind them of their right to the informed consent process. So after consenting, how do you deem if consent is valid? So it must be given voluntarily, as I said. It must not be received under duress or threat. Patients must be knowledgeable, that is, they understand the procedure that is being performed, as well as the risks, the complications, and possible alternatives. And the consent must be given by someone who is deemed to have capacity to offer this consent. So what is decision-making capacity? So the Mental Capacity Act in 2005 defines a patient with capacity with three important facts. They must be able to understand the information that is relevant to the decision. They must be able to retain that information. Once that information is retained, they have to weigh that information as a process for making a decision. And the fourth one, I said three, but it's four. They have to be able to communicate that decision, whether by talking, using sign language, or any other means. So all adults over the age of 18 are presumed to have sufficient capacity to decide on their own medical treatment, unless there's significant evidence to suggest otherwise. So what are the conditions that can affect capacity? There are numerous, right? So there are mental health conditions such as schizophrenia or bipolar disorder, for example. Dementia can affect capacity. If a patient has severe learning disabilities, if there's damage to the brain, either by a stroke or any other type of brain injury. You could have physical or mental conditions that cause confusion, drowsiness, or a loss of consciousness. And if a patient is intoxicated either by drugs or alcohol, all of these can affect capacity. What do we do with a patient that is deemed to lack capacity? So in this case, there's a need for either psychiatric or judicial input before informed consent can be attained. This patient should not be left out of this process. And we must understand, we must find out what their level of understanding is. If psychiatry is to be involved, the patient should be informed that we need to get these other doctors on board. Proxy decision maker must be identified either by the patient from a period when they had capacity prior, or one can be appointed from a court. And sometimes in non-emergency cases, informed consent can be gained on behalf of the patient by the next of kin, in the event that a lasting power of attorney, which is a legal document, has not been designated. So just to discuss about children and informed consent. So children, these are typically under the age of 17, they cannot provide informed consent on their own. As such, the parents must permit any surgical treatments or interventions on behalf of them. So there are exceptions to this rule. There's a rule where there are legally emancipated children who may provide informed consent for themselves. So there are examples of an emancipated minor. These are minors who are under the age of 18 and are married, either serving in the military, able to prove that they are financially independent, or they are mothers of children, married or not. What are some exceptions to informed consent? So we'll discuss two exceptions. There's the emergency exception. So this is based on the premise that a reasonable person would not want to be denied necessary medical care because he or she happened to be too incapacitated to consent for treatment. So it's generally felt that for the physician to proceed in an emergency situation without consent, these factors must exist. So it must be a true medical emergency. The physician is truly unable to obtain consent from the patient or their next of kin, and the proposed treatment is for the ultimate benefit of the patient. So when these factors are fulfilled, we can have an exception to informed consent and move forward with an emergency procedure. There is another exception. Sometimes there are incidental findings that can arise during an operation. So a surgeon who discovers an incidental finding in an anesthetized patient who was already consented for another procedure, they have to fill these three factors, right? So they must take into account all of the relevant circumstances. This could be either clinical or otherwise, and determine that performing an additional intervention is necessary in the interest of preserving that patient's health. Two, there must be no reason to believe that that particular patient would object in these circumstances. And three, that the surgeon who performs the additional procedure has a reasonable care and skill with performing that additional procedure. So it's only then shall it be presumed not to incur civil or disciplinary liability for proceeding without consent. So just on this, I had a small case I just wanted to briefly summarize. It's an interesting case that's related to this topic. In this case, the operating doctor, the surgeon, possibly adhered to the second and third points, but they may not have taken the first point into full consideration. So that is the relevant circumstances of the case that I'm going to discuss, right? So this case occurred in a foreign country in the year 2018. It involved a 20-year-old female who consulted a gynecologist for endometriosis. So she underwent a diagnostic laparoscopy. And during that, it was identified that she had left fallopian tube disease. 6 days post this diagnosis, she presented with worsening pain. She had signs of sepsis, and that gynecologist decided that further surgery would be indicated for possible removal of that left fallopian tube. So she was consented for that, but it wasn't discussed that there could be a possibility that she could have removal of the contralateral right-sided fallopian tube. So during the operation, the left tube was removed as planned, and the gynecologist observed that the right fallopian tube was inflamed and it had pus that was draining. So this gynecologist, they told the court that they did not consider allowing the woman to wake up from the anesthetic to discuss these findings with her because they considered it an emergency situation. And they were concerned that if the right fallopian tube was left alone, it would remain as a nidus for infection, which could possibly worsen the patient's sepsis, and ultimately the patient would need a further operation and have to undergo another set of anesthesia and possible ICU admission. So they made a decision that they would remove both tubes. And as I stated before, this patient was 20 years old and she never had children, so she was rendered infertile. So based on this, she brought a suit against the gynecologist for damages, and the gynecologist actually lost, as it was deemed that there were other less invasive options that could have been taken, and the patient really should have been woken up from the procedure and advised on the findings before moving ahead with such a procedure that would have lasting effects. Because of those particular circumstances, she was a young woman, she didn't have children. The court said that most gynecologists would not remove both fallopian tubes without gaining consent to do so. So even though she believed she acted in the patient's best interest with regards to the infection, each case has to be taken into full consideration. This is a picture, basically just to be connected to that previous case. And we'll move on to withdrawing consent. So patients with capacity can withdraw consent for continuing surgical treatment. If it's during a procedure and the patient indicates that they want the procedure stopped, it should be stopped as soon as it is safe to do so. And the consequences of not proceeding should be fully explained without implying coercion on the patient. It's important to let patients know that stopping a procedure will not compromise their care. This included back and front of the consent form that we use here in Mount Hope Hospital. I did find it was interesting to include because I've been using these consent forms for a couple of years in Mount Hope, but I never fully read that there was a part that was directed to us as physicians on the back side. There are instructions to doctors and dentists. So it states that patient has the right to grant or withhold consent prior to examination or treatment. Patients should be given adequate information in a way that they can understand about the proposed treatment and possible alternatives. So patients are allowed to decide whether they will agree to the treatment, and they may refuse or withdraw consent at any time without prejudice to their continued care. This patient's consent to treatment should be recorded on this film. So I thought that was interesting to include. All right, so we've now come to the end of my presentation. I thank you for your time. And these